Hello everyone, and warm welcome to our final webinar to Global Rural Health Summit 2026. This is our third webinar, and it's focused on advancing Indigenous health workforce models. I'd like to welcome you all to this webinar, and I'll just give you a brief introduction regarding Rural Wonka, what we do, and why we exist. Health needs a global voice, and rural communities are diverse, but the challenges of distance, workforce across, and equity are shared. So, Rural Wonka has grown from networking rural doctors to supporting coalition across rural health professionals and institutions. And four ways we create impact. The work is practical, we connect people, build skills, influence policies, and grow rural leaders. The core message is rural health is not a niche, it is central to universal health coverage and health equity. Our main idea is to connect, educate, advocate, and enable through various fellowship, grants, rural health, and conferencing platforms. So practical education is for rural realities. There is need for evidence-based, resource-appropriate learning for clinicians who often provide first contact in emergency care. And that's why we have started on Rural Wonka Institute of Learning, which is built around short practical modules that can be used by busy rural practitioners on mobile devices and in low resource environments. We are first starting with four key modules, one on emergency medicine, next one is mental health, third is palliative care, and fourth is innovation and technology. These are our four pilot projects which we are trying to develop with various partners, emergency medicine through emergency special interest groups, and mental health with our working parties, and similarly for others. Our main goal is to bridge the gap between tertiary center knowledge and rural first access care. So, from isolated excellence to connected action, Grace identifies, connects, and supports organizations already doing strong rural health work. So, Grace is Global Rural Health Action, Collaboration, and Excellence, which we recently launched during our Wellington conference. A Rural Wonka framework to formalize collaborations, share proven solution, and build a resilient global force for rural health. So GRACE is defined as it's designed as a living, context-sensitive network built on reciprocity, practical knowledge sharing, and rural-led actions. Initially, we had got five groups: academic centers, health service center, professional organization, workforce support centers, multidisciplinary centers. But now we have added the sixth group that is focused on the indigenous group. So it's an invitation to join and lead. The Indigenous health workforce work stream must be community driven and led by Indigenous people. So we invite partners to co-create a collaborative work stream focused on educational pathways and early pipelines, culturally safe training environments, innovative recruitment strategies, retention support, and work-based culture, and also focusing on systemic barriers and policy hurdles. So your experience can help shape practical strategies, policy messages, and shared resource for rural and indigenous health workforce development. I'll share you the link how we can join after this webinar. So rural and indigenous voices in global policies. Rural Wonka engages with WHO and partners to ensure policy reflects in rural contexts. So recent advocacy priorities in primary healthcare workforce. We have got team, we believe in the teamwork. So we have got family doctors, nurses, midwives, community health workers. As its base, indigenous-led research, intercultural care models, local governance, public health plus primary care. So policy principle is to allocate resources not only by population size, but by geographic and social determinants of health. And building future rural leaders, recognition, mentorship, and innovation. So Rural Wonka supports people and ideas that can strengthen rural health systems. Through fellowships, recognize exceptional contribution to rural health. Through our flight grant, it support young ambassadors and grassroots innovation projects in rural health. And we have got a rural seeds, which develops medical students, resident, and young doctors passionate about rural health. Also, simple idea connect all three. It recognizes leaders, funds innovation, and mentor to the next generation. Rural Wonka membership is free. Family doctors, generalists, GPs, nurses, medical students, and all rural health professionals are welcome to join. And it's the link is there. You all can join. I'll be sharing the link in this group also. And recently we had got very amazing conference in Wellington. We had got 987 registered attendees from 39 countries, 96.7% was attendee satisfaction. And it left a legacy, Aotearoa New Zealand Declaration on Rural Health 2026, focusing on rural policy, rural proofing, Indigenous health rights, workforce reforms, and equitable funding. It's also led to some brilliant academic outputs, 403 abstracts submitted, 36 published abstracts, one oration, three research papers, and one published legacy document, and global momentum. Grace was launched there. Indigenous leadership were elevated and ongoing action linked with Rural Wonka Institute of Learning. So, message for today is that Rural Wonka conferences are just not only the meetings. They create declarations, collaborations, learning platforms, and long-term rural health action. Next, our Rural Wonka conference in 2028 is going to be in Calgary, Alberta, Canada in April 2028. And so you all can join us, lead with us, and build with us. So you can join Rural Wonka, join Grace, and lead Indigenous collaborative work. Thank you.
Thank you, Kumar. My name is Ojisto Horn, Dr. Ojisto Ganawahere Horn. I am I am from Haudenosaunee from Canada and or Mohawk from Canada, and I'd like to introduce to you the speakers that we have this morning. Before we begin, I just wanted to say that we are here as Dr. Kumar has just done to announce the next Wonka conference and to build some early momentum for this upcoming conference. And I'd just like to introduce the five speakers or the speakers this morning and the WHO representatives who are going to be speaking in the next few minutes. We have Theodora Swift-Kohler, who is leading the WHO work for the development of the Global Plan of Action for the Health of Indigenous People. We have Pascal Zern, the Senior Advisor of the Health Workforce. We have Donald Warren Oglala Lakota. He is co-director and professor, Johns Hopkins Center for Indigenous Health, president of the Indigenous School of Medicine in the United States. We have Rajni Juan Ganguly, the founder and chair, Project Setu Foundation in India. Dr. Darlene Kitty, Cree Director, Indigenous Program at the Faculty of Medicine at the University of Ottawa, Canada. And we have Michael Edmonds Maori from New Zealand to complete the list of speakers. So afterwards, we will have a quick audience discussion about what these presentations will be engendering, and a quick question and answer, and then we will close. And then at that time, thank you and await the next meeting. So just to start, because we are at 3:12, we're a few moments behind schedule. And so I would like to invite Dr. Kumar, did you want to carry,
Yeah.
to describe the road to the summit? Thank you.
Okay. So, Arisha isn't here, so I will just give a brief about the TUFH 2026 conference. It's conference with the main theme of Van for Health Equity, co-creating social innovations for responsive and resilient healthcare. Website has already shared this, and there will be some different summits happening. One of that is a Global Rural Health Summit, but apart from that, we also have got IDD, Autism Behavioral Integrated Health Summit, Social Innovation in Health Summit, Women's Health Summit, and Aging Health Summit, and Mental Health Disaster Preparedness Summit. So the TUFH 2026 conference is having lots of exciting programs, exciting summits along with it. Global Rural Health Summit is going to be on 6th, and all the details regarding different programs. We have got multiple papers, panel discussion, interactive dialogue sessions, and finally there will be a Manila Declaration. And we are also recording all the transcripts from all the previous webinars, and we'll use all the discussion for our final Malida declaration. So whatever you'll contribute in this webinar will be carried forward and it will be reflected in our Manila declaration. Thank you.
Okay, thank you very much. Theodora Swift-Kohler, I would invite you to come up and speak about what it is that you're here to talk about.
Okay, excellent. Thank you so much. It's really a pleasure to be with you all today. I'd like to please ask my colleague Pascal to project the slides.
Okay. Hello, everyone. Can you see the slides?
We can, but they're not yet in full screen. Do you mind putting them on full screen?
Yeah, I clicked. Maybe it may take a bit of time. Is it okay now?
Not yet.
I think it is on my side, I think.
Hmm. Okay, maybe if you're able to reshare, maybe disconnect and reshare.
It's still not on the
No,
mode. Let me,
no.
if I move, is it moving or
No. Sorry about this.
because on my side, so let me stop sharing and share again.
Um, okay. Well, I can.
Can you see, or is it still a problem?
No.
It's always like this when we're trying, it was fine.
I'll try from my side and see if it
Okay.
comes up. Now, present. Oops, it's not working. Can everyone see the
Yeah.
slides here?
Yeah. We can see the
We
slides.
we can see them. We
Okay.
just have to open them ourselves.
Oh,
Yes.
you
Yeah.
have
Yeah.
to
There we
open
go.
yourselves.
Perfect.
Well, thank you. They are now in full screen.
Okay, all right. So sorry about that, the connection issues there. So yes, as we were saying, we're very happy to be here and talk about some of WHO's work related to Indigenous health workforce. And I'm here with my colleague Pascal Zorn, who, as Ojitso said, is from the WHO Health Workforce team. And a key piece of related work that we wanted to talk about today is the development of a global plan of action for the health of Indigenous peoples. And this was specifically called for through our World Health Assembly in 2023, where we had a resolution dedicated to the health of Indigenous peoples, Resolution 7616, that called on the WHO Director General to develop a global plan of action for the health of Indigenous peoples in collaboration with Indigenous peoples, with member states, and other partners, including non-state actors such as Rural Wonka. Since then, we have done a variety of activities towards that end. The first was a situation analysis conducted with Indigenous and non-Indigenous researchers, really understanding what are the health issues that are key to be addressed through the plan. Then we had input sessions for the co-design of the outline and the first draft, including with Indigenous peoples organizations and also with member states, i.e., for example, the units and ministries of health working on Indigenous peoples' health issues. Then we had, after the first draft, we had an online global call for inputs. We had 130 sets of inputs that were received. We're grateful for the collaboration with Rural Wonka for enriching also the draft through their inputs. And we received many inputs from academic institutes globally, including academic entities that are led by Indigenous scholars. And then also we received many inputs from Indigenous peoples organizations around the world. We then had meetings based on all the inputs. We had meetings across WHO with the different programs that would be responsible for the different action domains in the plan. And then also because WHO is part of the wider UN system with the different agencies in the interagency support group, really looking at how we could ensure collaboration, joined up working for the priorities and action domains of the plan and to enrich the subsequent draft, which was indeed the second draft that went online in March of this year for further consultation. And the first set of consultations we did was with Indigenous peoples organizations across the 7 social cultural regions. That was in March. And part of March, then we went on to regional consultations between April and early June in all 6 WHO regions globally. We also had side events, not only just this past April, but in previous years as well, at the United Nations Permanent Forum on Indigenous Issues for inputs to the development of the action plan. We then had sessions at our executive board and our World Health Assembly, where member states had a chance to comment both on the process as well as the substance of the emerging plan. And right now, we're about to issue online the 3rd draft for further enrichment. And I wanted to just say, while what I'm sharing in the screen here is still in a draft format, it's a sneak peek in terms of advanced sharing of the draft for the text of the global plan that will soon be released in its 3rd draft form. This is the action domain that looks specifically at Indigenous health workforce issues, and it calls for member states, Indigenous peoples, and partners to work together for the development and strengthening of policies, programs, and initiatives that build, reinforce, and expand the Indigenous health and care workforce, including Indigenous-led education and training pathways and removal of systemic barriers in admissions, retention, and professional development. Drawing from the WHO guideline on health workforce development, attraction, recruitment, and retention in rural and remote areas, as almost 3 out of every 4 Indigenous peoples globally live in rural areas. This includes culturally appropriate, bundled, context-specific strategies to develop, attract, recruit, and retain Indigenous health workers across all roles and occupations, as well as adequately recognizing, compensating, and integrating into multidisciplinary teams Indigenous peoples who are community health workers and traditional medicine providers, as applicable to the context. So what you're seeing here has been enriched through different consultations, including one that we had that was quite critical to the formulation of this at the last WONCA conference. We had a side event in Wellington that was, as Pratush has mentioned, that side event was really critical for informing this action domain and will be critical for the follow-up, including through the GRACE initiative. So we're very pleased to partner with that, with GRACE for moving this forward, and also other entities that are working domestically on the issues. I know Carl Briscoe is one of the speakers today and a key example of the type of entity we look forward to collaborating with to move this action domain forward. I'd like to now hand over to Pascal Zurn from the Health Workforce team, who will say a bit more about the related work of that team. Over.
Thank you very much, Theodora. So now I will talk about health workforce issues and also how it relates to Indigenous people problems, because one important piece of work related to WHO regarding health workforce aims at improving access to health workers in remote and rural areas. And as in many countries, Indigenous people tend to live in remote and rural areas, so this is particularly important. That work started in 2010 with some initial guidelines where the focus was more on retention. Then in 2021, there was new guidelines adopting a broader framework in terms of attraction, development, deployment, recruitment, retention in remote and rural areas. For all those guidelines, here the one you see, that's the latest one of 2021. WONCA also played an important role, and some of you here were part of both the 2010 and 2021 guidelines, so that's really great to have this collaboration. And for the 2021, what really came out is that there's not one single approach that works. It's more a combination of approaches that is the most efficient. And four main domains were identified: one related to education, one to regulation, one related to incentives, and finally, regarding personal and professional support. Also, what was important that was emphasized is that the issue of having people train from remote and rural areas and then working in remote and rural areas is something very important. And it's all that discussions around the rural pipeline. So that was really something that was clearly emphasized. And if Theodora, you can move to the next one. Yes. And no, just there was one part, yeah, thank you, I wanted to highlight. There's a challenge with animated slides. Sometimes they're too animated, sometimes not. So after these guidelines, we also felt the need that we need to have more evidence, more guidance on how country implement those recommendations and how countries can be supported to monitor and evaluate the policies. So that gave way to discussions, and then a recognition that there was a clear need to have some guidance to help countries. So for the implementation, there was one part in the 2021 guidance, but we thought it would be important to develop more the aspect of implementation as well as the monitoring and the evaluation, and to build that. Now, can I have the next one, please, Theodora? Okay. So work started about a bit more than a year and a half ago, really to develop an implementation, monitoring, and evaluation guidance. So briefly, this is still work ongoing, and also with some of you involved and rural WONCA as part, and we appreciate that very much. So there was a technical working group that was established for this, and we started with a scoping review of what is the evidence from the literature, but also to go through gray literature review and key informant interviews to highlight maybe some issues where we had not too much information, or also from countries where we thought it could be interesting because it was not captured by the traditional literature. We had countries like Fiji, for instance. So that was really the basis for this work. Next one, please. And in terms of the approach, the way that guidance is developed, we have 4 phases. So first one is about understanding the situation analysis. Phase 2 is about the design of the interventions. The third one is about the implementation, and the phase 4 is about the evaluation and also what we learn and to adapt. But one important element is that involving the community for each of the phases is very important. And that is in the case, for instance, for if there's indigenous people in certain areas that there's the idea to do this implementation, monitoring, and evaluation guidance in regions or country. So that community should be really involved. That's something important. Then here the phases is also flexibility because some countries might have already done one phase or another. So the idea is that it provides flexibility. You start where you want to start. And in terms of the documents that will be finalized, so there'll be a short guide also for policymakers, for the community as well. Like this, people own the product because they were part of the development. More a detailed guide, maybe for more researchers or more some of the people involved in the detailed implementation. And there will be also a lot of detailed annexes. Next one, please. Now, we haven't finished the work yet, but already some of the elements that are coming out from the discussion, the interaction. So for each of the phases, so for the planning and design, what really comes out as something key, and it was really emphasized by the members of the technical group, is we really need to understand the context. We need to understand and involve the community that will benefit from those guidance so that they really own and they influence the development. That's one element. I will not go through each of one. And for implementing and adjusting intervention, also here it's clearly that we need a multisectoral participation, commitment, and strong partnership, as sometimes health workforce issues are beyond the health sector as well when they want to be addressed. And for the monitoring and evaluation, so here, important to have something rigorous, but what came out as well, we need also to adapt to the context. Because in some occasion, there were some very sophisticated model to monitor that were developed without taking into account the reality of the context. And as a result, there was no capacity, or it was too much of an effort or too long to collect all the data for that monitoring. So there was some of the elements that already came out from the discussions. And now, next one, please, just as an example to illustrate the first phase, the planning and design, where we said that we need to have a good understanding of the situation. So here it is some work that has been done regarding the state of Chhattisgarh in India, which has a large population in remote and rural areas, about 70%, and about 30% tribal population. And here, what came out is a lot of vacancies for doctors. You can see that in most of the district, vacancies were about 50%. So there was what we call the health labor market that was done, that is to understand better the situation and why we have this, as well as a review, and that's the second document. It's improving retention health workers in remote and rural areas. That was done in different countries, including one in the state of Chhattisgarh in India, to get a better understanding of the situation. So here we understand a bit the issue, and also some policies were done. So that was just an example. And in terms of conclusion, I think in the context of the work of WHO, we're really very happy that we have that Grace has been established. I think that will really be an important milestone in terms of knowing what works, also maybe what doesn't work less, or to learn from that. And we'd be very happy to collaborate with you on those issues. Thank you very much.
Thank you, Pascal. I'd like to share my slides to continue on. We are about 10 minutes behind, so I'm going to be quite quick. I'm going to, let me see, I'm going to share, is requesting allow and share. Okay. I'd like to know if you can see my slide or you. Can you see
Yes,
my
we can.
entire slide?
Yes,
Okay,
we can.
wonderful. So I was asked to talk about advancing Indigenous health workforce models. My name is Ogisto Horn. I am a physician in the Ganyakehaga or Mohawk community of Akwesasne. And we are situated at the border of Canada and United States. I'm also, and so our community is bisected. So I'm very aware of some of the things that are happening in the United States that are really affecting our health, particularly our environmental health. I'm also the Indigenous Physicians Association of Canada current president. We also have Dr. Darlene Kitty, who is on, and she is also a former president of IPAC. And so today I'm just really going to very quickly talk about an overview of some of the things in terms of getting our youngsters to be interested in medicine. I'd like to start by saying we have many, many treaties in Canada that are all based on this early idea that is integral or found within one of our wampums, which is a physical treaty. It's called the two-row wampum. And in this wampum, you have vessels of the colonial government and the Indigenous peoples, each in their own vessel going down the river of life side by side. And each vessel carries their own language, their governance structures, their culture, and their ways of being in their boat, and in the other vessel, the other people are in their boat, and we go down the river of life side by side in parallel, and not one vessel goes into the other one or causes waves so that the other vessel would tip over. And the idea is that we have people who have a different paradigm and ways of providing health, and so do we in allopathic medicine. As a physician, I am firmly in the allopathic great flagship of Western society, but I have in my community a lot of people who really commit to the traditional forms of health. And so we have to always ensure that we include both paradigms when we are talking about health. As we know, when our children are born into this community, into our communities, they come bearing a certain set of gifts. Where I come from, and we know that our children are born into this world carrying this gift. And as the child comes into this world, and there are all of those who are present and very excited about this new baby, we recognize that we have the responsibility to create the spaces for that child to meander through their childhood, adolescence, and adulthood, and try on different experiences and discard some, pick up others so that they can actually find out what their gift is. And so, if we're trying to have more individuals, young people, pick up the gift of providing healthcare, we really need to start at a very young age, because everybody with their gift, once they have received all of the support, then we have a really good mixture of a lot of people with a lot of different gifts working collectively to make sure that the people are, the community is healthy. And so we really do need to start from a community, family, and a child approach when we're talking about the Indigenous health workforce. In around 2015 or 2017, the late Honorable Murray Sinclair, who is a judge He died last year, but he was the chairperson of something called the Truth and Reconciliation Commission. And what they did was went through all of the history of the residential schools that happened in Canada. And at the very end of all of this process, came out with 94 calls to action, and there are six of them that have to do with health. And one of them is to increase the number of Aboriginal health professionals and ensure their retention in communities. And so, what we are talking about today very much aligns with the tenets and the calls to action of the TRC, as it's called. Before he passed, Murray Sinclair wrote a book, and he describes who we are, four questions for a life and a nation. Because when we're talking about health, we really are talking about a holistic framework, not just the allopathic health that we as physicians learn. So, where do I come from? Once we answer these questions, it really does help us, decide and our space in time, and where we're going, and what our purpose is, and if we are going to become healthcare providers. So the questions are: where do I come from? Where am I going? Why am I here? And who am I? And so these are the questions that we need to help our youngsters ask themselves. So hopefully they can choose working in the health field. As mentioned, I'm the president of the Indigenous Physicians Association of Canada. This is this has been a association that has existed for well over 25 years through different iterations. But it's over the years has become more and more organized because of the TRC's calls to action and the increase of Indigenous students in the medical schools. There is an increasing number of these Indigenous students who are passing through and successfully finishing their medical school and their residencies. And so now we have 600 members of IPAC. And so we spend quite a bit of our energy towards the mentorship and the support of Indigenous students and residents in medicine. It is very much aligned with the allopathic, like the Western medicine model, but we are increasingly talking about traditional medicine and expanding the scope of how our new workforce is looking at ideas of health. Because when we finish medical school, we have many of us, the expectation is that we are going to go back home. However, when we go back home as allied doctors, we in our mind may still have some of those traditional teachings, but as we went through allopathic medicine, those teachings slowly were explicitly removed so that we could learn this type of medicine. And then when we go back home, we look different to our people, and it's really hard to re-engage in community because of the changes that we have had to go through as we went through medicine. And when we work in community, it's really hard because you have three different competing sets of expectations. You have the expectations of your medical licensing authority with all of their clinical practice guidelines and their expectations of how you are to practice safely as a physician or health professional. And then you have in Canada, we have the federal, I'm sorry, and those medical licensing boards are provincial, but the communities are actually under the federal government mandate. And so we have a whole lot of processes that are administered by our chiefs and council and our Indian band system, and that is federal oriented. And so they do not necessarily work with the provincial government in terms of providing safe spaces and support for those physicians working in their community. And then finally, you have the expectation of the people. who've gone through their own history and narrative of colonialism. And so there's a lot of trauma. We're talking about trauma-informed care. And of course, when they leave the community to get healthcare outside of the community, they many times experience quite a bit of racism. And so when we show up as doctors, in particular, we are outward facing. We represent a medical establishment, which may have been very harmful. And so, in understanding that, we have Indigenous doctors who go back home and they bounce between these three different groups of expectations, and it can be very, very difficult for them. So, I do think that not just training doctors and expecting them to go back home is really going to be sufficient. We really need to think about how we are going to create the soil, the garden, so that when our people do go back home, that they are going to be supported to provide safe care and have a sustainable practice so that they can stay there for the long term. Part of that includes having mentors who look like our youngsters to be involved in providing teaching and care. In the community that I live in, we've had about 10 years or 220 months of rural rotations for medical students from McGill University, Queen's Medical School, and the University of Ottawa. And so having Indigenous preceptors and supporting those preceptors to work in community is one of the ways, not just to improve the understanding of non-Indigenous people or students working and eventually, training and then working in our communities. We really need to create those spaces for our own youth to be able to see that it's actually possible to come back and work in our communities. So, as physicians, as a family doctor, we go through a big process of meeting the health needs of our people through all stages of their life cycle, and we all have in our own communities different traditional ceremonial practices which acknowledge those changes as we go through the life cycle. And so, working with the traditional people to mirror what they're doing with different community members as they go through their transitions of life is actually a really strong way of working collaboratively side by side as an allopathic physician with our traditional medicine people. When I say traditional medicine people, I'm also talking about midwives, the doulas, community health workers, and the traditional medicine people, those who know the plant medicine. So it's a very wide group of people that still are very strong in our communities, who have up until recently been very estranged from the Western medicine model, and it's very reassuring to see that this is something that we are going to actively be addressing. And so I'm going to stop sharing my slide, and I would like to move on to the next speaker. Thank you very much. The next speaker is, sorry, have I stopped sharing my slide?
Yes.
Okay, thank you. So our next speaker here is going to be Donald Warren. He is Oglala Lakota, and I'll let you start. Thank you very much.
Okay, thank you so much. I really appreciate that, Ojisto, and very good background information and segue into this discussion as us to speak on culturally safe training environments. And I can give this group an update on the development of the Indigenous School of Medicine. And I'm also a physician. I'm Oglala Lakota, and have training in traditional Lakota medicine. And I've seen the extreme differences between modern medical training and traditional medicine training from an Indigenous perspective. So why do we need an Indigenous school of medicine? Well, of course, we have terrible health disparities, and we have terrible workforce shortages. And that's really the reason we're having this discussion. And I really appreciate the World Health Organization and WONCA both for having this discussion and putting Indigenous issues on the forefront of these discussions, because we really need a dedicated effort to improve Indigenous health, but also workforce development. And we're terribly underrepresented in the healthcare workforce and in our medical training. As Ojisto was saying, we don't really integrate traditional Indigenous medicine into the curricula. And we're really taught to think in just one way. And it's really a colonized view of what medicine and healing is. In the United States, American Indians and Alaska Natives represent about 3% of the overall population and 0.3% of physicians. We're terribly underrepresented in the physician workforce. In the state of South Dakota, where I am from, where I live and work, we're over 10% of the statewide population, but again, 0.3% of physicians. So we have a tremendous challenge in terms of recruiting more of our own people into medicine, but then providing culturally safe services. So part of the development of our Indigenous School of Medicine included interviewing current Native American medical students. And we're about to publish these results in academic medicine, but about 60% of the medical students talked about inadequate representation. Half of the students said they felt devalued and excluded. Many of them stated things like, I felt like I had to check my culture at the door, that I couldn't be who I am as an Indigenous person and become a physician. There's also lack of mentorship. When we look at all of the medical schools in the United States, we have 0 American Indian deans for medical schools, 0. So we're not underrepresented, we're unrepresented. And then part of the challenge with that then is ongoing stereotypes, because we don't have leadership at the highest levels. So in terms of lack of exposure, some of our students even talked about the fact that when there are case studies involving an American Indian patient, it's the diabetic alcoholic is basically the only time that they're introduced to Indigenous case studies. What's going to be different at Indigenous School of Medicine? So it will be an accredited MD program, and it will prepare our students to pass the United States medical licensing exam. But what's the point of the medical school if we're not generating practicing physicians? But we're also going to focus on student wellness. In my own training, I went to Stanford Medical School back in the 1990s. And I'm sure many of us are familiar with this idea of education by humiliation, right? Using fear as a motivator. And if you answer something incorrectly, you're berated and belittled in front of your peers. So what we wind up doing is graduating traumatized scientists. And what we need is healed healers. And if we're just focusing on the basic sciences and not holistic care, then we're not really doing a good service to our students or their future patients. So we will be integrating traditional Indigenous medicine and holistic care. Ceremony, language, and culture is integrated into the curriculum. We just recently received a large-scale grant to develop this unique curriculum. And part of this will include the students participating in healing ceremonies themselves as part of their training. And as Ojisto said, we need trauma-informed care. It's interesting, in my own training, I memorized the Krebs cycle 4 times, right? For undergraduate biochemistry, the medical college admissions test, medical school biochemistry, and step 1 of boards. Never used it once, right? But I was not taught trauma-informed care. I was not taught motivational interviewing. So these are the types of things that we really need if we want to really make an impact on Indigenous health. We need our healers to be healed. So just very briefly, in terms of the framework of a medicine wheel, we look at spiritual, mental, physical, and emotional health. And in modern medicine, we call ourselves physicians, right? So we're saying on the front end, we're dealing in the physical arena. Physician and physical have the same Latin root, physic, meaning the natural sciences. But there's more to human existence than just physical existence, right? We also have to have good emotional health, spiritual health, and mental health. And when we think about the physician and the patient, if the physician is imbalanced and unhealthy, that has a direct impact on the quality of interaction with the patient. So this is not just an altruistic type of idea. This is a quality of care issue. But this is true for researchers and subjects, evaluators and programs, and public health professionals in the community. So we have to have healed healers to have a more effective system. And in our framework, we're not just saying patients and subjects, we're calling are the people we work with relatives. That these are the individuals that we're working with as physicians and public health professionals. So we've had several grants, a lot of outreach, local, national, and international. And the goal eventually is, what if we could have Indigenous School of Medicine campuses worldwide and working with each other and sharing that framework? So our initial campus will be in Rapid City, South Dakota. It's large enough to support a medical school. There's no current medical school in this city. And as I'd mentioned, over 10% of the population of South Dakota is Indigenous, but in Rapid City, it's closer to 30%. So we've done the feasibility study, and that's where we decided on Rapid City as the initial site. Our business plan is actually going to be completed this coming Monday, and our goal is early 2030s to have initial enrollment into ISOM. And we already have a building. One of the local health systems is leasing us a space for $1 a year. We're very, very fortunate to have this. But again, in the future, I would love to see multiple campuses. Let's have an international movement of Indigenous School of Medicine and integrate our traditional ways and student wellness into medical training. And I'll go ahead and stop there. Thank you so much.
Thank you so much. That was excellent. Actually really, really exciting to hear about and all of the work that's gone into this. I'm really excited to hear how your business plan goes through. And of course, 2030 is not that far away. So we're going to continue on with our next speaker. Dr. Rajni Jan Ganguly, the founder and chair the project Setu Foundation in India. And thank you very much. I'll give the floor to you. Thank you.
Thank you so much. And it's really a pleasure to be part of this esteemed panel. And I come from India, and I will be sharing my experience as part of my foundation trust, which I have founded in India. The slide sets will be shared. Should I share it myself or?
Yeah, please share it. Please share it.
Okay, yeah, I think, is it
There we
visible to
go.
everybody?
Perfect.
Yeah.
Yes.
Thank you so much. Thank you
Yes.
for waiting. So good morning, everybody. And so I am here to talk about innovative recruitment strategies for Indigenous healthcare. And I come from Project Setu Foundation Trust, which is a foundation which works with the rural population, the indigenous population of India. So when we talk about healthcare delivery, particularly in the tribal, in the indigenous communities, we often find ourselves in the very transactional, and certain numbers like, abstract numbers, doctor-patient relationship, the ratios, and something which is very dry and dry. But what I have realized in the past 14 years of working in Project Setu is that recruitment in Indigenous healthcare is not really a hiring problem, but at its core is a trust problem. Because today I want to share that in the last 13 to 14 years, how I have come to realize that the Indigenous population or any underprivileged population or population which is very, very cultured at its roots and it's protective, needs to be understood before we venture into any kind of, scope of healthcare. Now, the core. So what we have noticed is the usual approach is the very top-down postings, and it fails because the outsiders coming into that particular community, it lacks the root, it lacks the understanding. And professionals posted from these urban centers, they themselves are also not very well motivated. And I hear some of my colleagues, I just heard and I learned some of the wonderful work of motivation that has happened around the world. And yes, that is one type of approach that can be. But in the communities that we work in, we also realize that, why not really come out of this, the bureaucratic kind of vacancy announcements or these very cold and drab kind of approach. Instead, why don't we go back to the roots of the community and start working with them, try and understand where they're coming from, build in the trust that we can with them, and then in turn make them community health workers. So our entire approach is that health is not delivered, it is rather grown in the communities. So Healthcare, again, it is not really a commodity that we've realized. It cannot really be manufactured in the urban settings in like a packaged box, but in the most sustainable kind of healthcare worker is where he actually belongs. So they do not need to be taught about what is the care of the community that is required. They already love doing it. They really know about their community. They're passionate about it. They do not need to be really incentivized or motivated because they are there and they want to go out and do for their community. So, sustainable healthcare, I feel, is raised out of the same soil, out of the same self-help group of women and the villagers that are there, out of the same local livelihood networks that supports these community survival. So coming back to our ethos of nurturing these local livelihood, which builds into an organic healthcare workforce. So number one, we believe that we recruit from the livelihood networks. Now we have the self-help group of women, we have the farmer collectives, we have the artisan circles in the indigenous communities. They are already existing. They have trust-rich, they have organized groups, and they are rooted to the community members. So we help them and to sustain their livelihood, to market their products which they have. It can be an art piece, it can be, some kind of cloth, some kind of material, it can be any food product, and we help them do the branding, the marketing, and take them to the fairs which are outside the villages, and they can earn their livelihood from there. So we lead with vocation and not vacancy. We start nurturing these talents first through on these handicrafts, the organic agricultural workshops, the livelihood, the security associated with this lowers this trust barrier and really highlights the potential. And last is the anchor that is there in existing trusted institution. So people will not really step into a healthcare role or a system or a government department that they do not trust. When you start working with them, the recruitment works when it is really guided by a nurtured kind of foundation that has stood with the community and the community starts trusting. So some of these, the Setu pathway is what we call it. Some of these activities that we've done really is the agricultural training of organic farming with the local farmers of the indigenous community. We have the vocational workshops. If you can see here, we conduct dance workshops. Then we work with children. There are artisans who make different kind of handicrafts, and we work with them. We understand, we talk to them, we try to get to the roots, and then we start branding and marketing these products and keeping the foundation family intact. And there comes building of the trust and the rapport. And finally, they are nurtured into the community health companions. So livelihood integration guarantees purpose-driven retention. The whole purpose of founding Project Setu Foundation, yes, we realized there were a lot of gaps, there were a lot of negatives. But then we thought that why don't we start with something small, something humble, but something that starts with a positive, something that is rooted to the community where we don't have to really get people from outside, rather work with the community, help them out to enable that trust factor and thereby driving them to motivate health care as health companions in the community. And last but not the least is the word Setu, which essentially means bridge in our national language. So this is the action roadmap for the other regional programs. So we have active networks, we have the groups, we have the capacity building programs in different villages. At present, we are working in 3 villages, 2 in West Bengal state of India and 1 in the Madhya Pradesh state of India. And we map the active networks So the vocational training is also conducted by other organizations, other NGOs who we collaborate with, and we bring them to conduct the vocational training. And then we partner with these trusted foundations and integrate this vocational health pathway. So basically, we are trying to scale this wisdom, scaling the community-led recruitment that requires discarding of this traditional vacancy model, traditional bureaucratic model, and we must build these bridges to sustain the livelihood security and the trust that first allows the clinical service to emerge really organically. So this gives me an immense joy. This is one of our teams who work in the Bakura village of West Bengal. And recently, this was one of our indigenous workers, as a lady, a self-help group lady, who used to make pickles, and we did the branding. And then we took her to a fair. There was an orange festival happening in the town nearby, where the local bureaucrats and the politicians also came to visit her stall. So that is where I want to end my talks. Thank you very much for patient hearing.
Thank you. Thank you very much for your presentation. I really like the idea of purpose-driven retention. So thank you so much for your talk. We're going to go on because in the interest of time, I'd like to introduce Dr. Darlene Kitty. She is the director of the Indigenous program at the Faculty of Medicine at the University of Ottawa here in Canada, and she is Cree from the community of Chisasibi up in northern Quebec. Thank you very much for being here, Darlene, and the floor is yours.
Morning. I'm just trying to share the right screen. Do you see it?
That's perfect. We can totally see your.
Okay. Now I can't see you guys, but that's okay.
That's okay.
All right. So I'm supposed to be talking about retention, support, and workplace culture, but I changed the title because I think workplace culture comes first, then support and retention, and you'll see why in a minute. So thanks for having me. I'm going to be looking at burnout and turnover, and looking at workplace culture in a little more depth, and then talking about long-term support and mentorship. Oops, sorry. So I'm Cree family physician working in Chisasibi First Nation in northern Quebec on the east coast of James Bay. And I work for the Cree Board of Health and Social Services of James Bay, or Cree Health Board for short. I'm also director of the Indigenous program at the University of Ottawa, and I'm on faculty at McGill University. I'm an IPAC member and also Society of Rural Physicians of Canada member. So I got a big heart for Indigenous health and rural and remote medicine. And I don't have any conflicts of interest except for receiving teaching stipends. This is where I'm from. So I don't know if you see my cursor, but Chisasibi is the most northern community on the James Bay coast, the smaller bay in the middle of Canada, and then the Hudson Bay it's a bigger bay further north. My nearest surgeon, OR, and CAT scan is down here in Val d'Or, 1,000 kilometers away. So certainly I work in a remote community. So burnout and turnover is obviously something that affects many communities worldwide, be it rural, remote, and even urban. And it relates to work demands, which are increasing over the years for every profession, every health profession. It gives us multiple responsibilities in our daily jobs. We must multitask and sometimes that can be pretty crazy for physicians. You know, we're always doing extra work and being on call, and many skills are needed for nurses and physicians, particularly in remote and rural areas. You have to be pretty adept at emergency skills like intubating, delivering babies, things like that. And for workers who come from other areas into remote and rural communities to work, you know, especially if it's an Indigenous community, the culture might be unfamiliar to them. They don't know much about the culture or appreciate how their lived experiences affect their daily lives. And sometimes this can lead to culturally unsafe care. So, and obviously, you know, heavy workload can contribute to reduced job satisfaction. So, you know, the more that is needed for you and your colleagues to do your work, it has increasing demand on your body, and stress increases. This leads you to perhaps consider or taking action to leave your position, which ends up with a vacancy, and then staff will have to staff will have to work harder until you're replaced. And this could happen at a higher rate in rural remote settings. So it turns out to be a vicious cycle, you know, as you can see on the right side there. And the more work demands there is, the more burnout, the more turnover, and it starts over again. So how do we find a positive solution to this, or solutions? And I feel that the workplace culture is probably the best place to focus our efforts. So I don't want to stay too long on this, because we all know our realities wherever we are in the world. You know, the current state of work in the clinics and in the hospitals, across all the health professions, nursing, you know, social work, mental health workers, community workers, physicians. It can be very difficult and challenging at the best of times. In Quebec, it is particularly challenging. Our healthcare system is very much struggling. Nurses are leaving the profession or moving away. We're trying to do more with less. And, you know, for physicians, we're kind of stuck between a rock and a hard place sometimes, the way we are expected to work. So how can we improve this? What are some strategies that we can do? So for the Cree Health Board, I find, you know, we're all doing our work in our own little silos. And I've worked with management and the board of directors to address these silos and dismantle the negative environment that is sometimes felt. So some strategies that we have discussed and started are recognizing staff, you know, for their contributions. For example, having their 5-year, 10-year, 20-year recognition gifts, and recognizing them for their capabilities. So say someone has good clinical knowledge and experience, but maybe they can become a manager. So how can their supervisor support them to become a possible manager in the future? How about contributing to planning and implementation of services? We're changing our primary care model. So our physicians and nurses are now contributing through interviews and setting up these teams that are going to give a roster of patients their own health services by the same team, so they get to know them, and they know their history and follow them. So that's a bonus. In a rural and remote setting, sometimes you're not always seeing the same health professional So we're trying this new primary care model to do that. Learning and teaching. So we take medical students and residents from McGill University, and we always look upon them as potential future recruits. So we explain, and show them that, although we work in a challenging setting, it's great to expand your knowledge and skills, medical procedures, etc. And you're working in a different culture, and we share with them, what it's like to work with Cree patients and families, and show them the positive aspects of life here in Chisasibi. And so they really get a good sense of Indigenous health and strengths of the culture, and not just the negative stuff, like intoxicated patients coming to emergency department. So we also have Indigenous and non-Indigenous medical students and residents. So, doing their family medicine clinical rotation, but, supporting Indigenous students, to share, our I share my Cree culture with them. Well, both Indigenous and non-Indigenous students, but to show them, what it's like, the beauty of our culture, the beauty of the land. And so they really leave appreciating, this when they return down south to Montreal. One particular effort that we do is cultural safety training. So nurses get yearly training, and they have a cultural safety training session. And we also have it for our physicians, dentists, and pharmacists, which I'll explain later. So we look at the daily lives, as I mentioned, but also the historical, political, and social context. Staff support. There's various supports for the Cree Health Board staff, anything from training to increase their knowledge and skills. We have a Cree succession plan, and there's university courses given to certain admin staff as they gather credits to graduate with certificates or bachelor's degrees in management. So that's kind of through distance learning, and they're supported through that with, either perhaps a little bit of tutoring or encouragement to continue on their course and finish, and then they eventually go to a higher position in the organization. So there's advancement. There's workplace support for different departments. Sometimes it involves conflict resolution. We have employee assistance plan, which is available to employees. Physicians and dentists are not employees. We work by contract. So we have access through our professional organizations to get support. Same with nurses. But they also have some support through human resources and the employment assistance plan. There's also a collaboration that we aim to strategize for better recruitment and retention of staff, and this is ongoing all the time. Sometimes there's busier times of the season when we really have to gather forces and hire as much staff as we need, especially in the summertime and the holidays. And for Indigenous staff, our Cree staff, sometimes because of things happening in the family or the community, perhaps someone has passed away, it's important to recognize our traditions and resource persons that we need support from, like our elders and traditional healers. So that's a great resource for our Cree staff. So those are some of the supports we have for the long-term mentorship. There's different aspects of mentorship, either locally or down south. So IPAC has some mentorship there with our annual meeting. At Ottawa U Indigenous program, we have our mentorship lead, Dr. Pedequan, who supports our Indigenous students as well as myself. At the Cree Health Board, they have workplace mentorship where they pair our senior staff with new or junior staff, and they usually work together to learn and hopefully contribute to continuity of services. And if the senior staff retires, then you have someone following their footsteps. And then it's really important for support to your mentees, to keep encouraging them and help them when they need it, especially with the challenging work environments in the North in Indigenous communities. And for myself, I've been mentoring some Cree pre-medical and medical students over the years. We currently actually have 3 Cree medical students in school now, which is great. And there's one other Cree doctor who works in another community. So we're slowly building up our Cree physicians, but it's important, again, to support each other and them. I just want to say a few words about allyship. It'd be a long time before we have Cree physicians in every community, but it's important to work together with our allies. So many of our nurses are allies and our physicians, and they help us to advance Cree health. Cultural humility is an important part of that. And, if you put yourself in another one's shoes, you can see the Cree perspective, the lived experience, and understanding that will help them give culturally safe care. So some strategies to support allyship, the cultural safety training, as I mentioned, including anti-racism, engaging in the local activities, Cree culture and community activities, and then again, showing appreciation for staff efforts such as awards and celebratory events. It's important to build that positive, supportive atmosphere at work. Burnout and turnover, where there's multiple, as I already went through this, we have a lot of these factors that unfortunately contribute to burnout and turnover, but there's a lot of positive stuff now that we can help our employees. Time management, delegating tasks, and collaborating that helps with teamwork. Getting support from your supervisor and colleagues, your peers, building resilience over time, thinking about staff well-being and taking time off is very important. Sometimes that means going out on the land or going out of the community for a while and then coming back refreshed. Appreciating the culture, language, and traditions, focusing on culturally safe care and its training. And especially for rural remote locations, embracing the outdoors lifestyle. And eventually this will, this will lead to improved job satisfaction and retention. So some positive solutions, maybe not so easy to change. So similar to the previous diagram that I showed, perhaps increasing recruitment through colleagues. Sometimes word of mouth helps. Increasing salaries and wages, a little more difficult to do. Making sure staffing is adequate in the hospitals and clinics. Encouraging teamwork. And supporting each other to create a positive workplace culture. Physicians, nurses, and other health professionals will have good work days when that's all in place and less burnout, and they build resilience. And then this will eventually help with less turnover and more recruitment. And it's a positive cycle now, instead of a vicious cycle that I mentioned before. This can help it continue on. Just the last story. So this is the physicians, dentists, and pharmacists of the Cree territory, at least some of them. Every year we have a gathering, an annual meeting of our Council of Physicians, Dentists, and Pharmacists, and I am the president since 2012. And part of our cultural safety training was visiting Fort George Island near Chisasibi, where there was 2 residential schools. So here, the attendees heard the stories of a residential school survivor, and we also heard a story about the evolution of the Cree Health Board. So they really came to understand what our people have suffered, how they become resilient and strong despite those experiences, and how the Cree Health Board has evolved to develop their health services as their treaty right to health is mentioned in the James Bay Northern Quebec Agreement, which is a modern day treaty. So knowing all this, these attendees really appreciate where they work, why they do their work. And again, that helps build resilience, cultural safety, and anti-racism. So that's a strategy that we use that seems to help. And every year when we have our annual gathering, we do this cultural safety training. So you can see some happy faces there.
Yeah.
So that's it.
Okay, great. Okay, yeah, thank you so much, Darlene. That there was a lot of information that you shared with us. I'd like to quickly move on to our last speaker, Dr. Michael Edmonds, who is Maori, and he is from Te Toi Oraki Wahinagoa. I'm very sorry. I really need to brush up on my ability to pronounce some of these words. He's from New Zealand, and I'm going to let you take it away. Thank you so much.
Next time we see each other, I'll teach you. Okay, can you see my presentation? Okay, brilliant. Whai karoria ki te rungarawa pai marire ki te kuini Māori, ngā waihono i te pō, rire hau pai marire, kei aku rangatira tēnā koutou katoa, ko kari o i toku maunga, whaingaroa toku moana, poi hākena toku marae, Ngāti koata, Ngāti mahuta ngā hapu, whaingaroa toku kāinga, ko Michael Edmonds ahau. With the opening, it speaks to my connection and my people's connection to our ancestral mountain known as Karioi, our ancestral ocean known as Whaingaroa, my home known as Poihakena, and my name is Michael. I'm the CEO the CEO of an Indigenous health organisation on the west coast of New Zealand's North Island. We service a coastline of approximately 300 kilometres and a population of 10,000 people, of which 30% are Māori, so our Indigenous people of New Zealand, known as Te Toiora. I'm also an Indigenous representative of the Rural Health Network, Hauora Tai Whenua, who recently hosted the World Rural Wonka in Wellington, if you remember back in April. And I've shared a panel with a number of the delegates in this evening's presentation. I'm Māori, the Indigenous people of Aotearoa, New Zealand, and belong to Waikato Tainui and Hauraki tribes of the North Island. I was offered the opportunity to speak to navigating systemic barriers and policy hurdles, mostly a candid look at the funding limitations, geographic hurdles, and systemic policy barriers currently facing rural health, especially for Indigenous people of Aotearoa. 3 things are true right now in our country. Our funding for Māori and rural health is unstable, our geography is unforgiving, our policy settings still default to doctors and nurses as the only workforce that counts. But I also wanted to speak to and share to what is working an Indigenous health workforce we call Kai Awhina, and I briefly touched on that at the Rural Wonka. You think of it as a way of a community health worker who specialise in using traditional Māori methods and medicines and values to caring for patients. And it's one of the clearest, I would assume, and most practical fixes for a number of our issues we're facing here in Aotearoa. Now, when we speak of systemic barriers, I think it's important, and it's probably not new to any of my colleagues on this meeting. It's important that I speak to where it started. It started post-colonization 200 years ago of disrupted Māori health. And just a brief timeline, in 1860, shortly after the signing of our treaty agreement known as Te Tiriti o Waitangi, also known as the founding document of our country, the Crown confiscated 1.2 million acres of my people's land, forcefully took control of our waterways, rivers, oceans, and traditional food sources. At the same time, the Tohunga Suppression Act made the use of traditional Māori healing a criminal offence until 1962. Two of our own Māori leaders tried to build answers a generation apart, and neither succeeded. Dr. Maui Pomare, he was the government's first chief native health officer, planned a network of Māori-run hospitals in 1901. However, the promises of financial support from the Crown never came to fruition. 2 decades later, an elder of my own, known as Te Puia Herangi, built a hospital at our traditional meeting grounds and lands of Turanga Waiwai, intending it to be a Māori or Indigenous-run hospital, blending traditional medicine with Western medicine. Unfortunately, at the time, it was forcefully shut down from operating. And I think that's a good challenge where 100 years ago, where the degradation of Indigenous health has happened, if only we had established and set up these hospitals back then. Now, this isn't a new problem for us. It's approximately 200 years old. Today, about 92% of our wetlands are gone. Our traditional food sources have declined by roughly 75%. Now, in its own settlement, the Crown acknowledged our fisheries had depleted by pollution, overfishing, and spiritual desecration. And this was only in 2009 when we had reparations from the past grievances. Colonization didn't just take our land and the same 200 years less than, it took our healing systems to attempts at our own medical systems and the health of our ancestral waters. Now, the gap hasn't really closed for us, my people. Māori life expectancy has genuinely improved. We've had the largest gains of any ethnic group in New Zealand, Aotearoa, over the past 2 decades, but the gap in preventable death hasn't closed at the same pace. Over half of all Māori deaths are from causes better healthcare access could have avoided. Māori remain more than twice as likely as non-Māori to die from conditions timely care could have prevented, a gap that hasn't meaningfully narrowed in over a decade. Now, rural Māori, which I'm one, are far worse again than urban Māori, approximately 25% higher mortality rate if you live rurally or in isolated communities for Māori versus non-Māori. Now, by 2013, that was about 84%, the fastest population shift in our history, disconnecting my people from their land and traditional food systems. Why I'm sharing this with you is it's the backdrop of our Māori Health Authority, which was established 4 years ago, known as Te Aka Whaiora. Now, the Māori Health Authority, it was created because of the breaches of the Waitangi Agreement, known as Y257, but an inquiry found the Crown had breached our treaty agreement on our health. But within 2 years, the current administration disestablished the only Māori health entity or authority in our country. Unfortunately for us, there is a pattern, and us being Māori and Pasifika and our other ethnic communities, every time we've tried to build our own answers, it's been delicensed, suppressed, or removed. The opportunity now for us is to break the pattern, starting with our workforce, which I'll touch on shortly. probably we're going to speed through this, as we know it's difficult for all of us around the world, but funding, this is just my shortened version. When I brought up Te Aka Whaiora, our National Māori Health Authority, it existed for under 2 years and it was shut down mid-2024 with the introduction of the new coalition government. But recently, our own courts found that the government breached our treaty agreements, and this is currently sitting at the High Court of New Zealand. What replaced it hasn't kept pace. Our national health budget fell short by roughly $250 million last year just to cover inflation. Funding targeted as Māori primary care dropped by about $35 million, including $8.5 million cut directly from the Indigenous Māori health workforce. The exact workforce I'm arguing about shortly. Now, again, we speak of the patterns, a big announcement from the government, real cuts underneath and no dedicated Māori commissioning body left to protect the funding. Now, geographic hurdles, as I mentioned earlier, we service an area of 300 kilometres of coastline. We're the only Māori health provider along this area servicing our entire community, not just Māori people. Now, 1 in 5 New Zealanders live rurally, but for Māori, it's 1 in 4. Rural Māori pay the highest price. Life expectancy is 7 years lower than non-Māori. And rural Māori under 30 are twice as likely to die of preventable causes as their peers in a big city. Now, the workforce we currently have isn't there to meet this. We're short around 130 full-time rural GPs nationally, and a third plan to retire within 5 years. And you may have remembered Fiona raising this at the Rural Wonka. Distance itself makes a health risk. About 700,000 people in our country, so that's approximately 20% of our population, don't have timely emergency access to advanced hospital care, and Māori travel further than non-Māori for the same treatment. Now, we were also heavily impacted by the recent fuel crisis, so much so numerous people within my own community and within our service area couldn't afford the trips to our local hospital. So it's around 2 hours to get to our local hospital from some of the areas that we service. And of course, my staff personally covered a lot of the costs for people getting to emergency surgery appointments. Now, when I look at the policy barriers, now put the funding and geography together, and it's the system tilts towards the urban, the already credentialed, and the already connected. 2 barriers matter most. Our workforce planning still assumes doctors and nurses are the whole answer. For many communities, the rural barriers trust and access long before a clinician is even in the room. Our most effective community workforce has no formal recognition at all, known as kaiawhina. And I briefly spoke to this at Wonka and proud that I'm sharing this space with one of my heroes, Carl Briscoe of Australia. Now, kaimanaki is kaiawhina with no national registration, protected title, or recognised scope of practice. Now, there's also a structural gap in Māori-led decision-making. Regional health boards have influence on paper, but not the funding authority to back it up. Now, there are some fixes. Elevate our Indigenous health workforce. Now, this is at the heart of what I want to take away. Kaiawhina, as I mentioned earlier, are a community traditional Indigenous health worker. They do outreach, navigation, cultural support, and connect families to clinical care. Right now, this role has no formal profession behind it, no registration, no protected title, no guaranteed pay scale, no dedicated training budget. But the health profession itself has existed for over 60 years. I like to celebrate the fact that Australia, we don't often give things up for Australia, but Australia has, in our opinion, solved this through their Aboriginal and Torres Strait Islander health practitioner role as a fully registered national profession that passed, I think, over 1,000 registered practitioners in Australia last year, according to APRA, which is the Australian Health Practitioners Registry Association. Now, we don't have an equivalent here in Aotearoa. The Indigenous community health workforce already exists, though. We just need to elevate, support, and recognize the profession. Now, if there's a few key takeaways, I know that was a lot. A few key takeaways for the group this evening is watch what happens when you dismantle an Indigenous health authority without a replacement. We now have a documented case study here in New Zealand. 2, Indigenous community health workforce deserve the same seriousness as any clinical profession. Australia's proven it at scale. We're proving it within our own small regions. We just need regulation to match here in our country. Distance and funding compound each other. Every dollar cut from Indigenous-led health services lands hardest in places furthest from a hospital. Point 4, policy barriers arise when New Zealand or Aotearoa applies equality as sameness rather than equity as targeted support for communities facing historical and structural disadvantages. And 5, health should not be used as a political weapon as it currently is. It needs to be a shared commitment to equity, well-being, and collective responsibility. Now, you know by now, if you know me, we are storytellers, Māori. And I'd like to finish my presentation with we call it a whakatauki, which is a saying that my ancestor penned many years ago. Me he mea ka moemoea a hau kua hau anake. Me he mea ka moemoea tātou ka taia e tātou. Now, what that means is if I dream alone. If we dream as a collective, we succeed together, and it speaks to the power of collectivization, not just Māori, not just First Nations, not just Indigenous peoples, but as all peoples experiencing the same stresses and difficulties navigating through the world at the moment. And I would like to finish on that. So thank you very much for the opportunity for letting me speak this evening. And I hope to see you all in September.
Thank you, Michael. We we're all going through our own global response to the global changes that are happening, and I appreciate you for bringing that up right now and what's been happening in your country. I'm going to move on to Carl Briscoe. He is the CEO of the National Association of Aboriginal and Torres Strait Islanders Health Workers and Practitioners of Australia. So I'll have you reflect on the overall webinar. Thank you very much, Carl.
Okay. Thank you very much for that. So my name's Carl Briscoe. I'm a Googie LNG man from the far north of Australia. I'm based in Canberra on Ngunnawal Ngambri country in the nation's capital. So thank you to the 5 speakers for sharing their valuable insights, wisdom, and knowledge with us all. I'm sure we all took something away from those very, very informative presentations. So on reflection, we heard from Dr. Gisto, who spoke about advancing Indigenous health workforce models through early outreach programs and the development of sustainable education pipelines and pathways to encourage our Indigenous peoples to pursue careers in healthcare. With a great example of the river of life and the 2 boats going down the river with 2 paradigms of traditional medicines and mainstream, meeting the health needs of Indigenous peoples. We then heard from Dr. Donald Wone, who spoke about the culturally safe medical education, clinical training, which are inclusive and respectful of Indigenous knowledges and ways of practicing, with the Indigenous School of Medicine really filling a gap in a culturally safe learning environment for medical training that focuses on students' well-being, their holistic care, and Indigenous medicines, with the medical wheel being at the centre of the training. And we do look forward to seeing the positive progress of this training. We then heard from Dr. Roshni, who spoke about attracting healthcare professionals into Indigenous communities and rural areas and the best practice approaches which are community-led. The innovative recruitment strategies for Indigenous healthcare from the ground up, nurturing talents and livelihoods of nurturing health. Building the trust before becoming community health workers. I really engaged what she shared. You don't recruit a community health worker, you grow one. We then heard from Dr. Darlene, who spoke about the importance of identifying burnout and turnover with a supportive workplace culture that offers a sustainable long-term mentorship, with a key message that workplace culture being the best place to focus efforts in order to reduce burnout and turnover, as well as long-term support with succession plans for advancement of CRE staff, and the Employee Assistance Plan, which also assists to support recruitment and retention of staff. Mentorship, both locally and outside community, paired with the senior staff with junior staff. The importance of allyship in order to advance CRE health with cultural humility in providing culturally safe care. So, our last colleague who we heard from was a dear colleague from Aotearoa, New Zealand, Dr. Michael Edmonds. He rounded out the presentations and spoke on ways to overcome funding limitations, geographical hurdles, systemic policy barriers, which currently hinder healthcare planning in rural health. The systemic barriers steeped in history, which extend from the colonial the post-colonial settlement. Healing systems were affected with the life expectancy gap remaining between Maori peoples and mainstream, and even wider in rural areas by 7 years. Challenges include funding instability and shrinking of funding, workforce shortages and policy barriers, and structural gaps that still remain. Elevating Indigenous health workforce in recognising the professions to gain better health and wellbeing outcomes was one of the solutions we heard. Health is a shared commitment and a collective responsibility. So I do want to thank the 5 speakers who spoke tonight. Just on reflection of all speakers, the challenges are not dissimilar to what we are experiencing in Australia, significantly in relation to workforce challenges. I'd like to share some of the advances we have made in Australia, specifically in relation to cultural safety and elimination of racism from our health services. So within Australia, all registered health professions, doctors, nurses and midwives and allied health, they do come under a national law that states cultural safety, culturally safe healthcare needs to be provided to all Indigenous peoples, which is determined by Indigenous peoples. And in addition, the elimination of racism within our health services is also embedded into national law, which health professionals are all governed by. In saying this, the reach isn't limited to health professionals. It involves healthcare educational institutions, such as universities and health services, to meet certain accreditation standards of cultural safety within each and every course and healthcare setting. In relation to the professional association, which I oversee, I'm the CEO of the National Association for Aboriginal and Torres Strait Islander Health Workers, Health Practitioners. I'll just say NATSI for short. We are a professional body that provides ongoing support, resources, career pathways, pipelines to our members who work in hospitals and primary healthcare settings across Australia. Our professions of Aboriginal and Torres Strait Islander health workers and health practitioners, they're trained in comprehensive primary healthcare and are one of the world's only Indigenous healthcare professions that has national training and regulation to support the delivery of healthcare for our Indigenous peoples. In our organisation, we're underpinned by an Indigenous terms of reference. This means that what we do is rights-based, ethical and values-driven. So we recognise and acknowledge Indigenous sovereignty. We acknowledge the truth and recognise the ongoing harm caused through Australia's colonial past. The voices and aspirations of our Indigenous peoples and their rights to self-determination sits at the centre of everything we undertake in our organisation. We understand and value respectful engagements and relationships. We are accountable and transparent, and we encourage these traits in others. We respect and advocate for Indigenous leadership and decision-making. And we are very deliberative in the work that we progress. We prioritise long-term sustainable change over short-term piecemeal fixes. Our professions of Aboriginal and Torres Strait Islander health workers and health practitioners were established by our people for our people, which in itself is a pure demonstration of self-determination in action. In closing, I want to finish off by saying that we know that better health and well-being outcomes are achieved when Indigenous peoples are involved in the delivery of healthcare to Indigenous peoples. I would like to thank you for listening to me to the reflections of our speakers and how cultural safety and eliminating racism is being addressed, and the Indigenous health professions of Aboriginal and Torres Strait Islander health workers and health practitioners are embedded into our healthcare system within Australia. I'd like to encourage everyone listening tonight to look at how you may be able to embed an Indigenous healthcare workforce within your communities. Yalada, thank you.
Oh, okay, thank you, Nyalgoa. We are coming to the end of our session. Our next Q&A session, I don't think we have time because we are very over the time limit. And so I would like to ask Bruce Chater if he could please have some closing remarks. And I'm not sure how we can go about collecting some of the, if you have thoughts, but I'm sure they have been captured within the chat. And of course, we will be meeting again. So I will please ask Mr. Chater if you could wrap up with some closing remarks. Thank you very much.
Thank you very much. And it's just terrific tonight to see so many good friends. The speakers were just wonderful, and I think were very inspiring. It exemplifies what we saw tonight, the partnership between WHO and Rural Wonka, that we can work together not only with looking at the frameworks for good retention and recruitment of workforce, but also making sure that we have practical enablers on the ground. And I loved some of the quotes from tonight. I won't go through them all, but I think distance is a health risk. I think we know that. But health, the one I loved was health is not delivered, it is grown within communities. And the other one was, if I dream alone. If we dream as a collective, we succeed together. And I think that exemplifies what tonight's about. It exemplifies the partnership that we've got. Thank you so much for all our speakers. Thank you so much for everyone attending. I see we've had a really good participation tonight. For those who are speakers, we do have the opportunity for us to have a very quick get together after this on the other Zoom link, just to make sure that we're all on the same page about forming a collaborative of Indigenous organisations who can really lead this area within Rural Wonka. We want this to be determined by Indigenous people, for Indigenous people, and it's great to see the support of our WHO colleagues in doing that. So thank you very much. Wonderful night. And if we can, those of you who are speakers, if you come on to that other Zoom link very quickly, we'll have a bit of a chat before we. Though some of us are waking up, I see in the US, and some of us are nearly off to sleep soon in Australia. Thank you very much. Night night.
Thank you, everyone. So we're going to close this webinar Thanks a lot. Thank you, Ojitso, and everyone for joining us. Thank you.
Thank you. Thank you very much.
Everyone. Thank you. Bye-bye, everyone.